Okay, good morning, everybody. If you can, go ahead and turn on your video. Great. Good morning, everybody. Thank you so much for joining us on our first meeting of this advisory stakeholder group to the Patient Protection Commission. I'm going to go ahead and call the meeting to order, and I'm going to ask for Leslie to take a roll call. What I want to say is that today's meeting, really the foundation of it is a welcome and introduction. Make sure that everybody takes a moment to get to know each other. There's a large group of us. We have over 25 attendees online, and this stakeholder group consists of 26 members. So my goal is to keep today's time and have you back onto your normal schedules in an hour and a half. But as we make roll call, if you could just say here and then indicate who you represent so everybody knows it. I'm not sure everyone knows who everyone is. So as she's calling your name, please indicate that you're here and reference who you represent. So without further delay, Leslie, if you could take roll call.
Good morning, everybody. The first person I'm going to call is Angela Amar, and I'm going alphabetically, and she's the first one. Just to let you know, she represents UNLV, and she's absent excused this morning. And the second person is Carla B.
Hello, I am Carla B. I am a physician assistant. I currently work at Southern Hills Hospital in Las Vegas.
Thank you. Elizabeth Bullhouse.
Good morning, I'm Elizabeth Bullhouse. I'm a registered nurse at University Medical Center, and I believe I'm representing SCIU Local 1107.
Thank you. Chris Bossy.
Hello, I'm here. Chris Bossy. I work for Renown Health in Reno.
Thank you. Is Philip Burrell here? I don't see him. Okay. Mr. Tom Clark.
Good morning. My name is Tom Clark. I represent the Nevada Association of Health Plans. That is the private insurance companies here in the state, which makes up about 19% of the private insurance market.
Thank you. Jody Dominic, did I pronounce that correctly?
Yes, Dominic, thank you. My name is Jody Dominic. I am a nurse at Sunrise. I am also an instructor at Chamberlain and an executive board member, and I'm here today representing SCIU 1107.
Thank you. Vance Farrow.
Good morning, thank you. My name is Vance Farrow. I'm representing the Governor's Office of Economic Development, and I am the healthcare industry specialist for that office.
Thank you. Joseph Greenway. Mr. Greenway, I see you on there. I saw in the chat that you don't have visual, but I can see that you're there. We're going to move on to Joan Hall.
Good morning, Joan Hall representing Nevada Rural Hospital Partners.
Thank you. Maya Holmes.
Good morning, Maya Holmes. I'm the Healthcare Research Manager for the Culinary Health Fund.
Thank you. Shayla Holmes.
Good morning, Shayla Holmes. I am the Director of Human Services and Public Guardian for Lyon County.
Thank you. Lawrence Lerner, did I pronounce that correctly?
Yes, you did. Thank you. Larry Lerner. I'm a private practice nephrologist in Las Vegas with kidney specialists of Southern Nevada. I'm on the executive committee of Clark County Medical Society and the Council of Nevada State Medical Association.
Thank you. Asher Lysick, did I pronounce that correctly?
No, but it's okay. It's
correct me.
It's Ashore Lysick.
Oh, okay. Thank you.
Nothing like it looks. And I represent Pharma, which is the trade association for brand innovative pharmaceutical manufacturers.
Great, thank you. Karen Massey.
Hi, I'm Karen Massey. I'm the Executive Director for Northern Nevada Emergency Physicians, and I'm here representing the Medical Group Management Association. Thank you.
Thank you. Tom McCoy.
Good morning, Tom McCoy. I'm the Executive Director of Nevada Chronic Care Collaborative, representing those involved with chronic care across Nevada.
Thank you. Kyra Morgan.
Good morning, I'm Kyra Morgan, and I'm the State Biostatistician for the Department of Health and Human Services.
Thank you. Cody Finney is absent and excused. She represents Medicaid. And Sandy Rubalid.
Good morning, I'm Sandy Rubalid. I'm the Chief IT Manager for the Department of Health and Human Services, also representing HHS and Medicaid.
Thank you. Stacy Sasso.
Morning, Stacy Sasso, representing the Health Services Coalition.
Thank you. Todd Sklamberg. Did I say that right?
Yes, you did. Good morning, Todd Sklamberg, the CEO of Sunrise Hospital.
Thank you. Ken Thorpe was appointed and we haven't had contact with him, so he is not here. The next person would be Tiffany Tyler Garner.
Good morning, Tiffany Tyler Garner, representing the Children's Advocacy Alliance as Executive Director. Thank you.
Thank you. Jennifer Wakeham. We did not have a response from her yet either, so we will have to see if we can reach her. Bill Welch is next.
Thank you, and good morning, everybody. My name is Bill Welch, and I'm with the Nevada Hospital Association.
Thank you. Is Mike Wilden on? I don't see Mike Wilden.
I have a message that he is on, but I don't see him either. And if we could, looks like Phil Burrell.
Yes, I just saw Phil is on with us now. So
let's go ahead and mark Mr. Wilden in attendance, and we'll move on.
Okay. And Phil Burrell, would you like to say hello and let us know who you represent?
Sure. Good morning. Phil Burrell, Deputy Administrator, here with the Division for Healthcare Financing and Policy. Nice to meet you, Joe. Nice to meet you, everyone.
Thank you. We have a quorum.
Great. Thank you so much. All right, our next on our agenda is public comment. So if we can, let me just pause for a moment and see if there's anyone joining us on today's call that would like to speak during public comment. Your comments will be limited to 2 minutes. This is your time now. If you are joining us virtually, go ahead and raise your hand. If you're joining us via phone, press *9 to raise your hand and *6 to mute and unmute yourself. Okay, I don't have anyone in the queue, so I'm just going to close public comment and move on to agenda item 3 and launch straight into our meeting. What I'd like to do, everyone, is first, again, really, I just want to thank all of you for your willingness to participate as a stakeholder to this, to the PPC subcommittee. I really appreciate your engagement and willingness to be a part of this great effort. You were all chosen and appointed by the commission during their last meeting on May 19th. Each commission member selected 2 persons, and I made some additional suggestions of names, and they were all approved. And so that is the formation of this subcommittee. And if I can, I'm just going to take a quick moment. And if you are not familiar with the Peterson-Milbank Program for Sustainable Healthcare Costs, let me just provide a brief overview. The program really aims to help address the rising healthcare costs really recognizing that rising healthcare costs are stretching state budgets, employers, and families, leaving fewer dollars for other priorities like education and housing. The Peterson-Milbank Program for Sustainable Healthcare Cost advances state-based efforts to make healthcare more affordable for residents, employers, and states. The program provides technical assistance through Baylor Health to states that are developing targets for per capita trends and total healthcare spending statewide. Further, the program helps participating states analyze and collaboratively address the underlying drivers of cost growth. Nevada was accepted as a participant of this program, and we join Connecticut, New Jersey, Oregon, and Washington. This Stakeholder Advisory Committee was formed for the main purpose of advising the Commission on its design recommendations for the cost growth benchmark and for additional policy development, including but not limited to the implementation of a cost growth benchmark strategy, public reporting of benchmark performance, and the development and implementation of a data use strategy. It's also really meant to engage each of you as a stakeholders, as you are likely to be impacted by the cost growth benchmark strategy, to make sure that you are well informed and ready for its implementation in the future. The scope of this subcommittee is meant the scope of this subcommittee is to convene in between the meetings of the Commission and receive an overview of the preliminary design decisions discussed during the most recent Commission meeting and provide feedback to then be relayed back to the Commission. What I really want to stress is that this advisory committee, you will not be asked to agree upon anything. You are not going to be solicited to come to an agreement amongst each other. This is really meant as a platform to allow you to provide feedback to then bring back to the Commission during their next meeting. The purpose of today's meeting is really just as a welcome, an introduction. Wanted to make sure this is a large group. There's 26 of you that are officially a part of this group, and really just want you to have a kind of a background and an overview of the program, ask any questions, and then we're going to just launch right into Mr. Michael Baylett's presentation, in which he will be giving you a cost growth benchmark 101 presentation. Some of you may be familiar with this already, have seen it, but this provides you all with a foundation to start receiving feedback from you in the future meetings. So the Commission has made some preliminary decisions during their April and May meetings. We won't be addressing that today. We can talk about future meetings at the end of Mr. Baylett's presentation. Really, I'm just trying to get you guys all acclimated to the program's work, to your participation, and really give you an opportunity today to just kind of ask any initial questions before we kind of launch into feedback on the preliminary decisions that have been made or anything that you want to make a recommendation. So really today is meant for a listening session to give you an overview of what is ahead. So I'm going to pause there and see if any of you have any questions. If you don't, I'm going to try to keep my promise to get you out of here within an hour and a half, and I'll turn directly over to Mr. Baylett. But let me pause and see if I have anyone on the line now that has a question. Okay. Mr. Tom Clark.
Thank you, Director Schulhagian. Really, there's kind of a question and a comment. So in your remarks, there's been a lot of changes to the PPC based on legislation that was passed in the last legislative session. I, for one, was appointed or recommended for appointment to this stakeholder group from the representative that was from the private insurance companies. Now, we no longer have a seat at the PPC level. If the stakeholder committee will not make decisions and deliberate and put forward concepts or thoughts to the PPC, well, maybe we will, the minutes or however, what we deliberate here will be communicated to the PPC. I don't have a member on the PPC that I can communicate with to then advance whatever thought we have from the advisory committee perspective. So maybe the question is for Mr. Baylett. where does our role truly fit into this process, or are we just checking a box to listen to what is taking place?
So
Sarah, would you like me to respond?
Sure. If you want to respond, then I will add on to it for any kind of technicalities or logistics relating to the commission. But please respond for the stakeholder engagement.
Sure. So thanks for the question, Tom. This is not a check the box exercise. This is actually a broaden the tent exercise. Even before the legislation was passed, we envisioned this advisory subcommittee as a mechanism for more voices to get into the policymaking room, which is the PPC. And so while, Tom, you had a member who was on and isn't there anymore, there are other people right now in this group who never had a member who was there, so to speak, in the room. And so what our intention is to pose to you the same questions that we're posing to the PPC. We'll let you know what the PPC is talking about, but they're not going to finalize their decisions until they've heard from you and they can process your input. And so the responsibility that Sarah and I have is to bring to the PPC input and feedback, reactions to what they're talking about, so that they know how a broader group of people than just that group thinks about the important questions they're discussing. Sarah, anything you want to add?
No, Tom, do you have any other questions or follow-up that I can answer to you? But I think you said it perfectly, Michael.
I guess my concern, Director Shalhagian and Mr. Bailey, is that there are a number of people on the stakeholder committee that do have representation on the PPC, and so we're all in politics, right? We count intent and see where the direction of the stakeholder committee's decisions are being deliberated and made and recommended to the PPC. However, I guess I will have to rely on some level of hope that the PPC will hear the voice of a major industry in our state. And as the deliberations go forward, we'll make those decisions that will impact my clients directly.
So I hear you and I appreciate everything that you're saying and I understand. But what I really want to emphasize is, this is a public body. You guys are a part of, a public view. You are able to talk to whomever you'd like on the PPC. The new membership is yet to be determined. I don't know what that'll look like. There are qualifications, but exactly who will be appointed and whether you'll have a direct seat at the table is to be determined. So I can't really opine on what the commission will look like when it's for their new appointments. But I do encourage you to continue to talk to everyone on the commission. This is your voice to do so in a public way. This is why we're doing this engagement. We want there to be transparency in the discussion. We want patients involved. We want the public involved. And, the creation of this commission was really to bring a voice to the multiple voices to the table to address healthcare in Nevada. And if you feel that you don't have a direct seat at the commission level, I still hope that you participate at this level. I hope that everybody is watching participates at this level and you talk to any commissioner as you would in any public body.
Director Shohigian, can I ask a follow-up question to that?
Yep.
What is the timeline for appointment of new members to the PPC? And to your point of if we wanted to talk to someone on the PPC, let's say after this meeting, who is the current membership of the PPC?
So that's a little bit of a complicated question, but I'm going to try to do my best to answer it. And Greg, please correct me if I'm wrong on it. But as of today, all of the members on the commission will have their terms expired. And so their terms will end as of today, and the timeline for new appointments will be at the discretion of the governor's office, in which they have adequate applications and ability to make appointments. And so I can tell you that it is as soon as possible. The governor's office is fully aware of the commission's work, meetings, and particularly the work that we need to do for the Peterson-Milbank program. So I would say it's as soon as possible, but technically all of the commissioners' terms expire today. And so we're looking at new appointments as soon as we can.
Sarah, this is Bill, if I may.
Yep.
Thank you, Sarah. My questions, I have a couple questions. My first question is to Michael. Michael, I appreciated the answer to Tom Clark that you provided, in that the commission generally is not going to be making final decisions on much of this work until a bunch of analytic works and review has been done. However, I have been observing the PPC's meetings all along, and as you have been, each meeting, as you bring them along, you are getting them to make decisions that impact in how you'll be doing the study. Now, there's been some occasions where that decision wasn't made and it was pushed off to the next meeting, but it's clear that you're making decisions or asking for decisions of the commission on how to direct the study itself. Now, what you said to Tom was there were going to be no decisions, there was going to be discussions, and so at the end we would have our input would be available to the commissioners as they make decisions. So partially, I can see how that's going to work in some areas, but there's some areas that are specific to how the study is performed that it seems to me this advisory commission will be meeting after those decisions have been made. So how does our input then actually help provide insight to the commissioner on how they facilitate the study?
Michael, I can answer that too, because it's a little bit technical, I think. And so, Mr. Welch, what I'd like to say to you is that I think what I would like to propose to this group is, one, today's meeting is really meant as a foundation for you to kind of get acclimated to the benchmark work, the Peterson-Milbank program, ask questions. You are correct in that there have been some preliminary decisions that have been made that are helping advise this commission's work that the commission did in April and in May. I have asked Baylett to put together kind of a one-page summary that summarizes the decisions that have been made up until this point. And my suggestion is to circulate that to this group after this meeting and solicit you all for additional feedback, possibly one more meeting before the next PPC meeting. So then there will be a place in which you get an introduction today. You'll get a summary of what has been made for the commission. I will solicit this group for feedback thus far. And then when the new commission hosts their first meeting, what I would like to do is then take your feedback, knowing your preliminary introduction and knowing the preliminary decisions, and see if you have any additional feedback to give to the new commission prior to their meeting. So if there is an agreement with this group, I would like to propose one more meeting prior to the before the commission meets, so then that way I can solicit your feedback and then put it in a package and then share it with the commission and let them know that this
I certainly would be supportive of that, Sarah.
Okay.
I think it is, if we, I believe it's imperative that our input is provided to them in a manner that it can be reviewed before they make their final decisions. I guess the other question that I have, Sarah, and I just want to make sure, because we are a public body, and I heard you say, and Michael reiterated, that the purpose of this advisory committee is not necessarily to come to a consensus on any issue, but to provide feedback from the multitude of industries, services that we represent, so that when you take this advice to the Patient Protection Commission, there may be 26 different perspectives on any one particular point. Probably not, but there'll be various perspectives on a point. how do we, as not a commissioner, but as a member of this advisory committee, speak to the PPC under public comment? Because I suspect that that's how we'd be able to talk to them offline, one-on-one, certainly not as a collective group, because they can't meet as a collective group and comply with the open meeting law. But on a one-on-one basis, I understand how that would work. How would it work? And maybe this goes to the AG's office. How does that work if I were to speak at the next PPC meeting? Am I in the position to say I'm Bill Wells, president of the Hospital Association, as well as a member of the advisory committee, or would that be inappropriate for me to say that I'm here to speak on agenda item 8, and my objective would be to present my perspective as a member of this committee on that item? But I don't know that it will be legal or appropriate. So I just want to make sure that I'm clear so I don't get in trouble.
Yeah.
How do I introduce myself?
Great. I appreciate that, Bill. And Greg, maybe if you want to go ahead and address it, I think that would be great. But I should tell the group, you reminded me, Mr. Welch, that I want to make sure that everybody does know that this advisory committee is subject to open meeting law. Following this meeting, what I will be doing is sending a link. The Attorney General's office is going to send me some material to share with you all, which will provide you a link with some online training that you can watch at your discretion. And then I'll give you some contact information for Mr. Ott and the Attorney General, and perhaps another DAG to follow up on any questions that you might have too. So you will have that resource available to you in that training link sent.
Thanks, Sarah.
Thank you.
Greg Ott with the Attorney General's office, and it's a good question. Certainly you're able to give public comment to the PPC, and you're able to identify yourself in your private capacity, and also as a member of the Stakeholder Commission. What I think is important is if you do identify yourself as a member of this committee, you make it clear that you're not speaking for the committee. You are speaking as a member and in your personal capacity, because we just want to make sure that the PPC knows what capacity you're speaking in. So certainly you can identify yourself as a member, but identify that you're speaking in that individual capacity, not as a spokesperson for the group. If that makes sense.
That does make sense, and that helps me a lot. But thank you, Greg. Thank you, sir. That was all the questions that I had.
Okay, great. And just one more point of clarification, because I do hear, I think what you're saying is that there is a potential for a lot of feedback to be given to this group, and how are we going to summarize it and have it prepared and make sure that what you are saying is getting to the commission. And I want to assure you that Mr. Baylett and his staff, they are providing the technical assistance. So I'm here to facilitate these meetings, but Michael and his team will be collecting all of your feedback, summarizing it, and they will be making formal presentations to the commission at their next meeting, summarizing all of your feedback. And this will all be done at the next public meeting. The meeting materials will be shared with this group. So if there's any kind of changes or modifications, if something isn't accurate, there will be a process to make sure that everything is reflected appropriately. Okay, if there's not any other questions, it looks like we are good on sticking to our time, and I'd like to close out this agenda item and launch directly into Mr. Baylett's benchmark presentation. Okay, I don't see any questions. Michael, it is all yours.
Okay, thank you. So as Sarah indicated, this is a general introduction for all of you. I want to encourage you to ask questions at any point in time about anything that I'm presenting. In subsequent meetings, we will go more deeply into some of these topics. And as Sarah indicated, we will share with you the tentative decisions that the PPC has made thus far so that you can weigh in on them. And then I would say on a go forward basis, we will be a little bit more closely linked with the timing of the PPC meetings. But this advisory subcommittee is starting, probably a couple of months later than would have been ideal. So we've got some catch up to do first. So here's what I'm going to cover in our time together. I'm going to give you an introduction to what healthcare cost growth benchmarks are and what are some of the types of design decisions that have to be made in developing a policy. I'm also going to put in broader context why a cost growth benchmark and what's the logic model that's going to lead from setting a cost growth benchmark to slowing the growth of healthcare spending and improving affordability. We'll very briefly review the composition of this body. You've all met one another, but we'll share the stakeholder categories represented here, review our meeting timeline, and then I'm going to do a case study with you for Massachusetts. And the reason for Massachusetts is Massachusetts was the first state to do a cost growth benchmark. So we have the most history and the most experience to reflect upon for that state. So the program that you are advising was initiated earlier this year by the governor using his authority under the statute that enabled the creation of the PPC. And it's under that authority that he directed the creation of the benchmark program. As Sarah indicated, he did so in the context of Nevada being invited to participate in the Peterson Milbank program for sustainable healthcare costs. In March, he wrote to the PPC that he wanted their assistance with these 3 tasks: developing a cost growth benchmark, calculating and analyzing statewide healthcare cost growth, and analyzing the drivers of cost growth. For today, I'm going to give you an introduction really just to number 1. The PPC has not begun to discuss tasks 2 and 3, but those will be topics for them for future meetings. The Peterson program, as Sarah indicated, is helping improve healthcare affordability across 5 states. They're listed here at the bottom. And the participation means provision of technical assistance, as well as some targeted funding to support data analysis for the states. It's a 2-year program. And in addition to one-on-one technical assistance, there are also there are resources that are created for the states, and there are going to be opportunities for the states to come together. So the 5 states that you see here are the cohort. I want to note that there were 3 states that preceded this group of 5 states. So as I indicated, Massachusetts was the first state. Its legislature passed or created statute in 2012 to create their benchmark program effective in 2013. So they have multiple years of experience, and that's the reason I'm going to profile them. But then in 2018, Delaware and Rhode Island created programs. Connecticut and Oregon's programs became effective this January. So while they're in the same cohort, they're a little ahead. And Nevada, New Jersey, and Washington are all aiming to have their programs become effective 1/1/22. Any questions about any of this context so far? Okay, so I'm going to talk a little bit now about the whys and the wherefores of doing a cost growth benchmark program. So what is a cost growth benchmark program? What's a cost growth benchmark? I'll get to the program in a minute. So the benchmark is a per capita rate of growth for all healthcare spending in a state. Everything in, or at least to the extent that everything can be in. And the rationale for this is depicted in these boxes at the bottom. This is from national healthcare expenditures as measured by CMS. And this is a phenomenon that has repeated year after year after year. And what we see here is that healthcare spending grows faster than economic growth spending and grows a lot faster than wage growth. This isn't a 1-year phenomenon. So wages year after year are growing more slowly than healthcare spending. And that's developed a multi-decade cumulative impact. It's resulted right now, especially in the commercial market, with high deductible plans being the norm, and people with high deductibles now deferring accessing healthcare services because of the expense associated with accessing healthcare, which means that when they're seeking care, they are seeking care with more advanced disease states. So it's a frightening scenario from a patient perspective, but there are economic impacts as well on taxpayers because more and more dollars are going to healthcare and not to public safety or education or some other public good. an economic challenge for employers. So this is why states are pursuing this strategy. As I indicated, oh, and let me just say, by the way, if you have a question, just because I won't necessarily see you otherwise, if you could use the raise hand function, and then I'll pause. In Nevada, the program is called the CrossGrowth Benchmark. In other states, it's sometimes referred to as a CrossGrowth target. I might use both terms. I'll try to stick with benchmark, but just know both terms are used. You can see the benchmark states and the target states listed here. The reason California is in the target state is California has a bill that's advancing through the legislature this session, and it looks like it's going to pass. So California is likely to be the next CrossGrowth benchmark or target state. So a little bit on the logic model for a cost growth target or benchmark. Why would we think that this strategy would work? So I want to note that I think setting a benchmark in and of itself is probably not going to slow the rate of healthcare spending growth in any state. But if it serves as an anchor for a bunch of complementary strategies that help slow healthcare spending growth and improve affordability, then it's likely to have a powerful impact. And I'll just say there's some indication of this working in Massachusetts. There are other strategies that need to be identified and a set of linked processes. And so those linked processes represent what I'm referring to as a logic model. So I want to share on the next slide a visual depiction. I'm going to walk through these one at a time, this so-called logic model. So for a cost growth benchmark program, the first step is really to measure performance relative to the target or benchmark. And that measurement often occurs at multiple levels. The first one, though, is measurement at the state level. So if the PPC ultimately adopts a cost growth benchmark of X%, this would mean measuring, so how much did per capita spending grow in the state over the course of the year, and did we hit the benchmark or not? So that's a first step. The second step is analyzing what's driving healthcare spending and what's driving healthcare spending growth. And I want to distinguish those two things because they're not the same. In many states, there are areas that represent very large percentages of healthcare spending, but they may not be growing as fast as some other categories that are growing rapidly. So we distinguish cost drivers and cost growth drivers. And this analysis right here digs into what are the underlying factors that are contributing to healthcare spending and healthcare spending growth. These first two steps here in mustard and here in orange, they are performed using two different data sources. And this can sometimes confuse people, so I want to make sure that it's clear for all of you. Measurement against the cost growth benchmark is performed using aggregate data submitted by public and private payers. So when I say aggregate, I mean aggregated on a per person per month basis or per member per month basis. So that it might be looking at what's total spending broken into maybe 5 or 6 categories. Retail, pharmacy, inpatient hospital, outpatient hospital, for example. The analysis is performed not with aggregate data provided by public and private payers, but it's performed using claim data. And claim data allows for much more nuanced analysis of what's driving spending. Now, as maybe some of you know, during the last legislative session, there was approval for Nevada to create an all-payer claims database. An all-payer claims database is just what it sounds like. It's a collection of claims from public and private payers that are aggregated and then serve as an analytic resource for the state. There are a number of other states that have these all-payer claims databases. And so Nevada will be joining a legion of other states in creating it. And that will be the long-term data source for conducting these analyses. In the short term, without having one, Nevada will have to use a couple of proxies, and some of the things that we've talked about are using PEB, the Public Employees Health Benefit Plan, and using claim data from Medicaid. And those are large populations and serve as good indicators for what's happening at a macro level within the market. But in time, the all-payer claims database will be an even more robust source of information. So the first two steps, measuring performance against cost growth benchmark, and then conducting analyses to really dig into what's happening, what's lying underneath benchmark performance. The third step is reporting publicly on performance, both at the benchmark level and at the cost growth driver level. And allowing there to be a public dialogue about what's going on in healthcare spending in the state and what's driving it. All of this is a helpful foundation, but by itself, it's not going to slow healthcare spending. So these last two steps in blue and green, they're the critical ones. Blue is identification of opportunities and then strategies to slow cost growth. And those opportunities are identified in large part, but not exclusively, through the analyses over here in orange, which are then reported. So identifying opportunities through the data analysis, processing that information with a group of stakeholders, and then identifying strategies to slow cost growth. There may be some strategies that are identified that don't come directly out of the data analysis. Those are game two. Frankly, anything that can contribute to slowing cost growth and improving affordability is ripe for discussion. And then the last step is implementing the strategies. And the implementation can take place on a multilateral basis where there are a bunch of different stakeholder types that have agreed they need to work in concert to make something happen, or it can be unilateral action at the provider, employer, payer, and state levels. So at any of those. This logic model is an iterative process going on year after year, trying to create a meaningful positive impact on healthcare spending growth. So this is important content. I want to stop here. Ashore, I see you have your hand up.
Yeah, thank you. This is really helpful. And just going back to the governor's letter from March 8th, it looks like what you have been tasked with is really in the first probably 2 to 3 bucket areas. And I was just curious, you did acknowledge the all-payer claims database. Obviously, that's going to take time to develop, but what is BAILIT's timeline with the state of Nevada? And what buckets are you really focused on in your work with Nevada?
We're providing technical assistance for 2 years, and we're about 6 months in, or not even 6 months. So we will be around to see this through to implementation and to provide technical assistance to measuring performance on a pre-benchmark basis, and then once the benchmark's effective. And it's our intention to take this cycle all the way through. I would say our focus this year, though, is going to be most heavily on the first 3. We'll do a little bit of discussion on the last 2, but you need data analysis to inform the last 2, and we don't have it yet. But once some analysis begins to be generated using PEB and Medicaid, then it will be possible to begin to engage stakeholders in discussion about what's it mean and what are the opportunities. Is that helpful? Okay,
yes,
Bill.
thank you.
Thank you. Excuse me. Thank you, Michael. I'm glad you pointed out, and Asher had asked the question about the all payers claim data. Um, that program is going to take a number of years. In the way the legislation was passed, it's only the commercial payers who will be included in that APCD. Certainly, self-funded plans have the opportunity to opt in, and hopefully they do in short order, so that we do have a significant pool of data to be reviewing. And so I just thought it would be important to let everybody on the advisory committee know who hasn't been involved with the development of the legislation for the APCD, which we have been very supportive of and still continue to be supportive of. It will just take time to make sure that we're getting a broad-based payer group in there. So to your point, Michael, it will be important to be looking at the Medicaid data and the PEB data too, because commercial payers represent actually a very small percentage of insured lives in the state of Nevada in themselves. So that's something that we're all going to have to keep in mind as the APCD is growing and as we become more dependent upon the data that comes out of that organization. A question that I had on your prior slide, when we talk about setting benchmarks, and I understand the objective, and I think it's an important objective. We've got to get a handle on what is being spent on healthcare. We're going to be looking at the claims data, and my experience with the claims data coming out of CHIA, this is not a criticism of the CHIA staff. It's actually a criticism of the provider community. The provider community has not always been as consistent in getting their data accurately or timely submitted to CHIA. And certainly there could be some programming challenges that they may have that I'm not even aware of, but I do know that there is challenge with the CHIA data. And again, I, as part of the provider community, take responsibility for some of those challenges on the inconsistency and on the timeliness of getting that data. So Sarah, what I guess I would suggest as this is going forward too, is that there might be some close review of how data is being submitted to CHIA so that we make sure we're getting as accurate and timely claims data as possible. So that's just an observation that I would throw out. The question that I did have with regards to the other states and the benchmark, Michael, as I've understood your presentations to the commissioners, our benchmark is going to be a benchmark to Nevada itself. It's not going to be balanced or reconciled to what's going on in other states. Certainly we'll look at other states and we'll wonder what's going on in those states in comparison to what's going on in us. But the actual benchmark that we set, and I just want to be clear on this, is going to be based upon the factors that are driven in Nevada and not driven in Massachusetts. So for example, Michael, in Massachusetts, we know, you know, that they have basically an all payers claim system in Medicare, Medicaid, and everybody pays the same thing. So, and in our state, that is absolutely the opposite situation that we have, where we have Medicaid at one level of reimbursement, Medicare at another level, and your payers all over the range in their contracting rates. So to compare, to have a Massachusetts as a model will be important to look at, but to think that we're going to look like Massachusetts outright, I think will be a disservice to Nevada because of the factors in Massachusetts. Yes, they are the state that has initiated this. They're the model state to look at, but they have a lot of factors in place that make it a little bit cleaner there, I think. And I guess
so a couple things. So yeah, this is developed for Nevada. It's not modeled off of any other state, but we share what other states are doing. And the other thing I'll note is actually it's another M state that's got all payer rates. That's Maryland that does it. Massachusetts does not. Okay, but still,
thank you for that clarification.
Yeah, this is still, but the first point you made that I want to confirm is this is being developed for Nevada. And so when I share with the PPC examples from other states, it's only to give them a reference point, but it's not to say that Nevada should do anything exactly the same way as any other state, be it Oregon or Massachusetts or anybody else. Okay, I don't see any other hands, so
Excuse
Tom,
me,
go ahead.
I just want to thank Bill because he brought up the question regarding the self-insureds and the, we have all the confidence in the world that Sandy and her team at DHHS are going to stand up a quality APCD. We've worked very closely with her on that and others, and we're confident that the data that's going to be collected is going to be solid from my client's perspective. In the other benchmark states, are they all APCD states, and is that where you're getting the data? Or if in absence of them being an APCD state, how are you making sure that you get data from every single sector of the health insurance market?
Yep. Thanks for asking the question, Tom. So first, let me remind you, the benchmark measurement doesn't come out of the APCD, comes directly from the payers at an aggregate level. It's only this analysis activity that uses an APCD. Okay. The analysis of the cost growth drivers and cost growth drivers, all of the states but 2 are APCD states. Nevada is one, but it's obviously in the process of becoming one. The other state that does not have an APCD is New Jersey. And they don't even have legislation. So they don't even have one on the horizon. All the other states have APCDs. What's been interesting to observe is that in many cases, it was this program that led them to utilize their APCD in a really substantial way for the first time. And so it created a strong use case. It also, by the way, gave an opportunity to study something that Bill alluded to. And so I want to address it. It's the issue of inclusion of self-insured claims in the APCD. Some of you know, some of you do not know, there was a Supreme Court case a few years ago where Liberty Mutual challenged the state of Vermont on being required to submit their self-insured claims to Vermont's all-payer claims database. The case went to the Supreme Court and Liberty Mutual won. And so self-insured employer plans or self-insured union plans are under no obligation to submit data to an all-payer claims database, but they can do so voluntarily. In some states, they do so in decent number. In other states, they don't do so at all. So there's a lot of variation. To Bill's point, hopefully we'll see Nevada self-insured purchasers doing so. That would be helpful. But I want to share with you that in one of the other cost growth benchmark states, they did an analysis of healthcare spending in their APCD pre and post the Supreme Court decision. Because after the Supreme Court decision, a bunch of lives left their all-payer claims database. So they were able to see how much did the commercial population in the all-payer claims database change after the self-insured lives came out. And what they found was that there were differences. The self-insured lives total spending on a per member per month basis was not the same as the remaining lives, but the patterns of spending and utilization were comparable. And so my point here is, even if the APCD is, let's say, fully insured lives, PEB, and maybe some percentage, but not all of your self-insured market, analysis of those data will probably still tell you what's happening on a macro level within the market. So I hope that's helpful. All right, so these are the other states. You can see that this is something that started on the coast and is making its way in. Pennsylvania was blue because they have committed to develop it. They've had some stumbling with their legislature as of late, so we'll see what happens there. But otherwise, the green states are the ones that have an effective cost growth benchmark program, and those in blue have been working towards it for next January, and California seems likely to be next. There are some other states too that are talking about it, but these are the first ones. So each state framed the rationale for doing this in different terms, but they were always financial terms. So here you can see the framing that each of the states made when they said, this is why we're doing this, this is why it's important. And all based on finances. So the process for setting a cost growth benchmark and really the process that we've been walking the PPC through so far involves 3 major steps. So the first one is asking the question, how do we define total healthcare expenditures? If we're measuring spending against a CrossGrowth benchmark, what's included? What kind of spending? Also, what sources of coverage are to be included? And are we including only residents of the state, or are we including residents of other states who utilize healthcare services within the state? And these are questions that we've begun working through with the PPC. The second question is, how do you establish the benchmark? What's the methodology? Is there some reference points that are going to be used to set the benchmark value? And does the benchmark value stay the same, or does it change over time? And for how long should it or they be set? The PPC right now is in the midst of discussing number 2. The timing of changing the composition of the PPC in the middle of the discussion is a little unfortunate, but after we orient the new members, this is where the PPC discussions will be continuing. And so when we get together our next time, we will want to share with you what have they discussed related to number 1 and number 2, so that you can share your reactions and we can convey them back to the PPC. Ultimately, it's up to the PPC to decide what to do with your input, but it is our obligation and commitment to make sure that what you say is heard. And then 3, there's the question of how to measure and report performance. And the PPC has not discussed this yet. So the first question is, whose performance should be assessed? And then what are the criteria for when and how to report payer and provider performance? Because usually, well, I shouldn't say usually, in all the other states, payer and provider performance is reported or to be reported in the states that are new to this. So we are sequentially moving through these questions and some sub-questions below them with the PPC, and we're going to do the same thing with you so that you can share your thoughts. Questions about what we're covering? Todd. Todd, you have your hand up?
Nope, sorry about that.
Okay. All right. Anybody else have any reactions or questions to this content? All right. So what are total healthcare expenditures? Well, in all the other states, what's being measured is a combination of medical expenses paid to providers of services by private and public payers, including Medicare and Medicaid, plus all patient cost sharing amounts for those services paid for by private and public payers. So that's deductibles, coinsurance, and co-payments. It's not patient spending for services that are not covered by the payers. So if there are non-covered services that people are buying on their own, that's not included, in large part because there's no source of data to find out that spending. And then the third component of total healthcare expenditures is term of art, the net cost of private health insurance. This is really the administrative expenses of commercial insurers plus their operating margins for, or their margins really, their margins. And this is, so this is profit for for-profit insurers and its contribution to reserves for nonprofits. All of this is summed together and divided by the size of the population to yield a per capita measure. And what we are measuring with the benchmark is not total spending, it's how much total spending is growing per person from year to year. That's what the benchmark is about. Kyra.
Hi, yeah, I don't know if this is the right meeting, but I do have a quick question specific to the Medicaid expenditures. For our Medicaid business line, obviously we have both fee-for-service and managed care. And for our managed care expenditures, that's a capitated payment that we provide per member per month for that membership, which gets to the administrative kind of operating margin in a way for that population. But so I'm wondering, is the preference on the Medicaid population to quantify expenditures using the capitated payments per member per month to the MCOs, or is the preference to pull the claims experience, which is the cost that quantifies what the MCOs spent on that patient population?
Good question. So what we're looking to do for Medicaid is to have the MCOs report their actual payments to providers, because what you pay to the MCOs is not what providers receive. And so it's not direct service spending. So the MCOs will be asked to report their spending for their Medicaid line of business, and if they are doing commercial or Medicare Advantage, to also report for those lines of business. Separately for residual Medicaid expenditures, residual fee for service expenditures, or Medicaid specific payments like disproportionate share hospital payments, that will be reported separately directly from Medicaid.
Okay, and in Medicaid, we actually do have claims experience for, we do have the direct expense that the MCO paid the providers as well. I just wasn't sure which way you wanted to slice it. So we have the ability to do both.
Yeah, no, I don't think that you would be asked to do that. I think the plans would be asked to do that. Okay. Bill, then Karen.
Thank you, Michael. A question that I had, I understand, and I've listened to your presentations to the PPC itself, so I generally understand, but you raised a point today that we're going to come up with spend per member or per enrollee because we're using third-party data. Will this benchmark be broken down so that we know that per Bill Welch, there's X number of dollars being spent? 12% of that is hospital, 4% of that is doctors, 50% of that is pharmaceutical, etc. You see what I'm saying? Or will it just be one blended number?
One blended number, because we're not getting person level data from the payers.
Okay.
So they will say, on average for our population, or for this provider's population, it was $2 for inpatient hospital, $3 for primary care, $4 for specialist physician per member per month. But it's not Bill Welch level, because we're not asking for that data. And the reason we're not asking for that data, it's the same reason that self-insured employers aren't obligated to report to all payer claims databases. So we are stepping around that Supreme Court decision by not asking for claim level data, but by asking for aggregate data, which is how insurers can report both insured and self-insured spending.
Thank you for that clarification. And I probably didn't ask my question, based on your answer, I did not ask my question very well.
Or I didn't listen well, I apologize.
I used myself as an example, but what I should have said is, so we get the cost per person that is being spent on average as a general aggregate cost. And so is that cost by this aggregate number going to be analyzed by the various driving components of healthcare spend?
Yeah, so typically states collect spending in about 7 categories. So it's not super detailed, and you have to use the claim level data to dig down into it. But you'll be able to say, wow, we found out that last year pharmacy growth was the biggest contributor to spending growth. You know, that type of input you'll have, but you won't know, well, was it retail pharmacy or was it medical pharmacy? Was it price? Was it utilization? Which drugs was it? That information you can only get out of claims.
Okay, that's helpful. Thank you.
Sure. Karen?
I just want to quickly confirm, you stated that if someone purchases a service on their behalf, it's not in this because it doesn't show up as a claim. I would assume the same is true if there's a denial for a particular service or a down code or something like that by a payer. It's just going to be
a denial. Yeah, if there's a denial and it's not a paid service, then it's not included.
Even if the care is rendered. It doesn't.
Right.
Okay.
Yeah. So there's an important distinction I want to draw here. What we are measuring is not provider costs, it's payments to providers. And that can sometimes be confusing to people. But this comes up oftentimes when people say, well, what about care for people who are uninsured? Because that's a big expenditure for providers. But we're not measuring provider costs. We're measuring what are the payments that are being made to providers.
Thank you. That's an important distinction for the policy making at the back end.
Yeah. Thanks for your question. Larry.
Michael, I was just going to say, because I think that I've heard you say to the PPC in your response to Karen, while we're not looking at what the cost of the provider is for these services, we're again focused on what is spent on providing care to the population. As the commission looks at this and establishes their benchmarks, they do have the opportunity to take in factors that we're underbedded in this state. So we've had to build more hospitals, and so there's going to be additional costs that's going to have to be paid for. Our Medicaid pays pretty poorly in Nevada, at least to hospital providers. I can't say to all providers, but to hospital providers, it's one of the lowest in the country. If we are successful in improving that those are components that can be factored in to decisions or reactions to how well we did against that benchmark, as I understood what you said. Yeah. And I just think that it's important for everybody to understand, we're going to be looking at spend per the population, but once the benchmark's set, the community, the insurance community, the medical community is going to have an opportunity to come in and help present to the Patient Protection Commission driving factors of what might have made that look less than we were less than what the benchmark said, or we were greater than what the benchmark said.
Yeah, right. So at the end of the year, when there's information on performance, there'll be some interpretation of why and some analysis of why. In Massachusetts, one year, they went through their benchmark because that was the year Sovaldi came out. And everyone agreed that spending money to cure people of hepatitis was a good investment and a reasonable reason to exceed the benchmark for 1 year. So that certainly could happen in Nevada if there's a decision to make a big investment in increasing hospital rates. I'm not speaking for or against that, but I'm just saying if there was a policy decision to do that and it caused a big increase in hospital spending, then you as a state might say, well, we went through the benchmark this year, but we did it for a reason that was intentional. All right, Larry and then Vance.
Yeah, I'm curious if there's a delay in reporting claims, how does that affect the data, if at all?
Good question, Larry. So, unfortunately, measuring performance against the benchmark takes a long time. And so just this spring, the states that already have benchmarks were reporting out on 2019 performance. So early 2021, they're reporting on 2019. And that's because you've got to wait for 6 months for all the claims to be paid. And then you have to go through a process of collecting the data and validating it from the insurers. And experience has shown that insurers don't always submit the data correctly the first time. So you have to have a back and forth. And then after you've done the measurement and you feel good about it, you have to share it with the providers before it becomes public. And then there's some more back and forth. And then finally, everybody feels okay about the data and you publish it. Vance.
So I'm curious about a particular issue. For Nevadans that are receiving care outside of the state of Nevada, where Nevada is reimbursing rates at those other state levels, is that data just captured in the soup, or is there a way to distinguish what is being spent as a result of individuals that are receiving care outside of Nevada, or is that too detailed such that we wouldn't be able to know that?
So for benchmark level measurement, it's in the soup. But If you want to, as part of what we refer to as the data use strategy, which is the claims level analysis, to understand that, you could do a special analysis. So for example, Brown University does the all payer claims database analysis for the state of Rhode Island. And they did a study of how much healthcare spending was leaving Rhode Island and going to Boston teaching hospitals. So you could do a special analysis like that, but it wouldn't come out of the benchmark data because it's all aggregated.
Right. Okay. Thank you.
Yep. So in total healthcare expenditures, this is what goes in. Claims payments, they're basically claims for anything that's a covered service. So you see long-term care here. Long-term care is largely going to show up for Medicaid because it's a covered service for Medicaid, but there's not much long-term care covered in traditional Medicare or in commercial. Dental covered service for Medicaid, but very limited through the ACA for commercial. In addition, we've got non-claims-based payments. So this includes incentive payments, prospective payments, infrastructure payments, and then other types of weird and miscellaneous provider payments. The cost sharing that I talked about, and then the private insurer admin and margin. Who are the payers? Chris.
Thank you. I was just looking at the list of non-claims based payments, and I know I'm just curious if the state were to move forward with a provider fee program, would that be included? So the industry could be taxed in a certain way that would generate payments. Would that impact how we're perceived, or how we meet or don't meet our spending targets?
Yeah, that's a great question. It's one I've never heard asked. Let me get back to you on that for our next meeting. Okay. I think I know the answer, but I want to make sure I'm certain of the answer. Thanks for asking. So these are the provider, coverage types that are usually discussed. The ones on the left are always included. So Medicare fee for service plus Medicare Advantage, Medicaid, MCO, and fee for service and other, and then fully and self-insured commercial. The ones on the right, let me discuss them individually. Some states include Veterans Health Administration spending. The Federal Employee Health Benefits Plan is typically provided by one of the leading commercial insurers. And so it's not measured separately because it's collected already from the commercial payers. TRICARE, which is the healthcare program for the military, can be administered sometimes by a carrier that's not a major commercial payer. So that could be a special request. State correctional health, that is sometimes included by states, but not always. And Indian Health Services has been discussed. There's no state yet that's been able to pull it off because it's complicated accessing the data, but there are states that have interest and are pursuing it. So the PPC has to make a decision on each of these categories. By far, the majority of the spending is in the three categories on the left. I'm talking small percentages for the categories on the right, but some states want to be as fully inclusive as possible. And if the lift isn't too heavy to get the payer types on the right, then they choose to include them. Another decision is whose spending is included. The initial 5 states all decided to include spending for state residents, whether the care was delivered by a state provider or an out-of-state provider. Okay, there is the option though of having an out-of-state resident who receives care from a state provider included. And in fact, the PPC had interest in that. So if Nevada was to do that, it would be the first state to do that. But that's one of the decisions you're going to have an opportunity to weigh in on and say, we think that's a good idea or we think that's a terrible idea. Not today, but when we meet again. So now I want to share with you what a cost growth benchmarks look like in other states in terms of what the values are. And so this next slide shows you the values. So these are the 5 states that have benchmarks in effect right now. These are their values for 2021. Now, all of the states except for Rhode Island have values that have changed over time or will change over time. So this is just a snapshot for 1 year. You can see that they're pretty close in 2021. They're between 3.1 and 3.4%. The early states, that's Massachusetts, Delaware, and Rhode Island, they largely base their values on something called potential gross state product, which is a forecast of state economic growth from years 5 through 10 into the future. In Massachusetts, it's their forecast of economic growth minus 0.5%. In Delaware, it's their forecast plus 0.25%. And in Rhode Island, it's just the forecast with no adjustment. The states that have followed are not so far seeming to adhere to this approach. So in Oregon, they considered a whole bunch of factors before they arrived at their 3.4%. They're going to be there for 5 years and then drop to 3.0. Connecticut did a weighted average of state economic growth and forecasted state median income. It's a 20-80 split. And then they put it on a sliding, the descending schedule. So for this year, it's this weighted average plus 0.5 percentage point. But ultimately, it's going to drop to just the weighted average. So they're going to go down to 2.9% by 2023. All right, this just gives you a feel for what they look like. These percentages are generally somewhere around 2/3 of 20-year historical spending growth in these states. So they looked at what historical spending looked like, and they are trying to drop it. All right. The PPC has not settled on a benchmark value yet. So you will get a chance to weigh in on this and some of the methodological options that we discussed with them. But this is where they sort of left off when we last met with them. All right, so we still have a little bit of time left. So I'm gonna go through this quickly. I'm gonna skip over talking about the advisory subcommittee because I want to give you a look at our timeline and then a quick view of Massachusetts. So this is our first meeting today. As Sarah indicated, we'd like to schedule another meeting with you before the PPC meets again so that we can share with you all of their tentative decisions made to date. That way, we can feed back your input to them at the next meeting. And so their next meeting, fortunately, isn't until July 28th. So that gives us a month's time to squeeze in a meeting and for us to share with you where they are in their decisions. And you can say, go PPC, those are great decisions, or we think you should reconsider and here's why. And again, you don't all have to agree and you won't agree. And that's totally fine. And so then we've got a schedule for other topics that we're going to talk about with you in future meetings. And we want to time these conversations so they're taking place between PPC meetings. So we want to talk about performance assessment, governance of the benchmarks, transparency and accountability, the data use strategy, goals and analysis. This is the claims level analysis. Early ideas about cost growth mitigation strategies. And then we're going to share with you a final recommendations report and talk about implementation. So that's our plan over the coming months. Any questions about this? Okay. All right. I don't have enough time to go through all the slides in Massachusetts, so you can look at this subsequently, but I do want to share with you just a little bit about Massachusetts. All right, so this is performance in Massachusetts today, because the obvious question is, so does this work? So this is, it's an interesting story. So Massachusetts by statute, I want to note. And some states have established their benchmark programs by statute. The legislature did it. In some cases, it was through executive action by the governor. There's a mix. So initially, their statute said for the first 5 years, it's 3.6%, and then it drops down to PGSP minus 0.5%, so they're at 3.1% now. Over the initial 6 years, their spending averaged exactly what their benchmark was. Exactly. And then 2018, 2019 happened, and they shot way through their benchmark. And this has given a little bit of pause for thought on, whoa, what happened? And we thought our strategy was working really well, but what happened in this year? And they're still digesting that. The most compelling information we have about the cost growth benchmark in Massachusetts comes from looking at the commercial market. And the commercial market matters the most because government payers have some pretty strong tools that they can use to slow healthcare spending. And Medicare spending growth is very, very low across the country. And Medicaid spending growth varies from state to state, but states through their Medicaid programs have some levers that they can use to keep down spending growth. The commercial market doesn't have those levers. And commercial insurers are frequently price takers, especially in markets without competition. And much of the United States right now in the provider market is markets without competition. So it's really instructive to look at what impact the cost growth benchmark had in the commercial market in Massachusetts, because potentially that's where the cost growth benchmark will have its greatest impact. So the next slide looks at commercial experience in Massachusetts. And this is fascinating. So orange is Massachusetts, blue is the US. 2012 is when the legislation passed. 2013 was the first year of the benchmark. You can see Massachusetts was above the US, sometimes by a lot, just about every year. There's only 1 year when it wasn't. It was just slightly below. From 2013 on, Massachusetts is below the US rate of growth every single year. I would say this is the most compelling data that I've seen that indicates that the cost growth benchmark, at least through 2019, appears to have had some beneficial impact. The Health Policy Commission in Massachusetts, which governs this program, calculates this space between the blue and orange lines between 2013 and 2019 to be several $1 billion of savings. So this is the strongest argument for why this is a strategy worth considering. Now, I'll note that the way that Massachusetts executed it did not completely follow the logic model diagram that I showed you. Massachusetts, for example, does not do collaborative work with stakeholders to identify cost growth mitigation strategies and to implement them. So I just want to note that that all the other states are doing things exactly the same way as Massachusetts, but this is the most encouraging rationale for the strategy. Chris.
Thank you. Didn't Massachusetts do some major policy change, maybe expansion of their government programs or something? And I'm wondering what year that occurred, because I would expect that it would correlate or it would impact the commercial market if for some reason at some point more people were covered in a different way. Their need to have to have the commercial market subsidize other care might have changed. And I was thinking it was back in those maybe 13 or 14.
Yeah, it was earlier. So
okay.
Massachusetts did coverage expansion to cover the uninsured. They did that earlier. The rationale for the 2012 legislation was essentially, all right, we address coverage. Now it's time for us to address cost.
Follow-up question. Do you know what year?
I don't remember now. It's been too long, but it was earlier in the 2000s.
Yeah, I just wonder if it was around the 2010. From there, you start to see a cascading downward trend. Anyway, it would be interesting to find out.
It was 2006 when Mitt Romney was governor.
Thank you.
Thank you very much.
Yeah, I couldn't remember the exact year. Yeah, so it's quite a while afterwards.
My health policy professors from grad school would be proud.
That they would. All right, so this, yeah, I wanted to share this with you because I think that this is the important story. Sarah, we are at 2 minutes before the half hour.
Yep, I think that maybe if it's okay with you, we'll wrap up here and then connect with everyone on a date for a second meeting if it's at the pleasure of this group, if that's okay. Really what I wanted to do today was get you all started, introduced to this benchmark work, and then we will share a summary of some of the preliminary decisions that have been made by the commission back in April and May, and then hope to pick up the second half of this presentation and then also share the, and then solicit you for some feedback so far, if that sounds good. Does that work for everybody? Yep, I just want to keep my promise with these meetings to stay to an hour and a half. And again, we can always add an additional meeting. Your continued engagement and participation is really valuable. And so if there is a desire to meet an additional time, by all means, just communicate with us and we'll try to get something scheduled for all of you. Okay, Michael, I don't see anybody disagreeing with stopping here. Sounds good. So what I will do is we'll close your agenda item. For formality reasons, I need to now open it up to public comment. So let me take a moment and open up the agenda item for public comment. If there's anybody on the line that is joining us via Zoom and you would like to speak during public comment, your comments will be limited to 2 minutes. Please raise your hand now. If you're joining us on the phone, go ahead and press *9 to raise your hand and *6 to mute and unmute yourself. Okay, I don't see anyone wishing to speak during public comment, so I'm going to close public comment and close this agenda item and then open up our last agenda item, which, let's see if I get this right, is wrap up and adjournment. So is there anybody here that has any feedback that wants, before we adjourn, any additional thoughts that I can answer, questions? No? Okay. Well, thank you guys all so much for joining. I really appreciate it. I think I can't stress it enough how much I appreciate having you at the table and participating in this important work for our state and for the healthcare future of our healthcare system and the patients of Nevada. Well, with that, I will adjourn the meeting and connect with you guys for a future date later. Actually, is it June? So next month. So sometime in July, we'll get a date on the calendar if that's agreeable to everyone. Okay, sounds good. Thanks so much. Have a wonderful day, you guys.
Bye-bye.
Take care. Bye.
Great, thank you.